Ça ne nuit pas, il y a un petit rebord. Ouais. Caresse-pied. Ouais.
Slight delay. Oh, flight delay. So you're going to join me on the panel. Okay. Yeah, yeah. No worries. Olivier's joining us. Someone else was late. So we're going to have Olivier. What, 2 minutes? Oh, 2.5 minutes.
Yep.
Okay. Come join us.
Come on. This afternoon. Yeah, about 3:30 or so. I think I'm just on some panels after, so I'm here at 3 to 3:20, and right after that I will leave because my flight is at 6. So if I reach there,
I put you because when you
yeah, sure.
Then you of course will
But I'll just leave at 3:30. So will be plenty anyway.
By the way, I never take pictures after rotoblade, during rotoblade. Well, I mean, no. I mean, no, when I'm, before I remove, before you remove. No. Rotoblader can do things. You want to see it. I mean, normally the blood pressure and the EKG tell you a lot, and I use this special mix where you don't get no reflow. But at the same time, before you pull a wire out of that, the rotoblader. Go grab a snare and go down there. That's not fun.
Yep.
Not
robotic approach. No blood pressure changes.
But in the old days when we first did Rotoblader, I was proctored by Paul Tierstein. Came out to Vanderbilt in 1993. I did my first Rotoblader. I've been doing it for 26 years. And we were like using contrast as sort of the vasodilator.
Oh, yeah.
So we're constantly injecting contrast during Rotoblader. Now I just put nicardipine in my flush and adenosine. I put nicardipine and adenosine in my flush and something crazy vasodilator. I never inject
But
unless there's
I remember we used to give dye puffs constantly.
Yeah, the constant dye puff thing. Well,
it was
sort of like doing OCT type stuff.
I think it was what was the guy that invented it? David Oth.
David Oth.
David Oth used to teach that.
Yeah, and Murray's bookbinder was very involved,
Yeah,
and Paul Tierstein. And
I went to his course in Seattle for for certificate.
Sure. It's on.
Can we start? The mic are working, I guess.
We hear the mic. Good morning, everyone. I'm Dr. Tim Fischel. We have Dr. Pancolite and Dr. Obviously Olivier Bertrand on the panel here this morning. And we have a case from Ireland that's going to be transmitted. And I think we're ready to go if we can get that transmitted.
Hello.
Good morning.
Good morning.
Good morning. How are you?
We hear you, but we don't see you.
Okay, well, we'll try
Okay, that's
and
it.
change that. Do you see us now? Well, you'll see our hands. Hello there.
That's perfect. Good morning.
So let us introduce you to the team. My name's Colin Owens. Beside me is Dr. Mark Spence. and we have a great team here for the AimRADIal live PCI transmission from Belfast. We'll maybe just upload our PowerPoint slides.
Maybe you can see us a little bit better perspective now.
Yes, we do. Hello.
So could we go to the PowerPoint slides, please? So we have an interesting case for you today. So go back one, please. So we have an 80-year-old gentleman here on table who has a history of undifferentiated vasculitis, who's been followed up by the rheumatologists, currently on steroids with a quiet inflammatory response to that. He's undifferentiated interstitial pneumonitis with traction bronchiectasis and prostate CA under surveillance with hormone therapy. He has moderate aortic stenosis with a valve area of 1.1 centimeters squared and a peak gradient of 28, so his valve isn't quite there yet. He has a history of renal impairment with an EGFR anywhere between 40 and 50 and a chronic normocytic anemia with his last blood count being 100. He has not insignificant angina and was catheterized by one of our colleagues a few months ago via the right radial artery, and that showed 2-vessel coronary disease, which was calcified. Next slide. So here you can see, I hope this transmits. Can you see that okay?
Yeah. Perfect.
So they had some problems with the right radial axis. It was calcified and tortuous. You can see the right has a calcific proximal lesion, which is significant. Does that come across okay?
Yeah.
Yes, we can see it.
And you can see in the non-contrast, there's calcium on the left-hand side. Next picture. The spider panel on the left-hand side shows a rather unusual appearance of the proximal LED, which what looks like largely to be a healed plaque with further disease in the mid-LED, which is calcified. And if your eyes go to the non-contrast shots, you can see that in keeping with a gentleman with chronic vasculitis, steroids, renal impairment, his coronary tree is reasonably calcified. So we'll take you to our first live shot off the left. So next slide, please, sorry. Here's a picture of his LV. He's got good LV function. His aortic valve, as you can see, is opening okay, but is calcified. Next. And he had an MDT where the decision was due to comorbidities, he wasn't for surgery. We didn't feel his valve was quite there yet for intervention. And due to the likelihood of his coronaries contributing to his ischemia for double vessel PCI. I think the issues this case raises, which would be nice to discuss today, is how to deal with somebody who has anemia, who's at increased bleeding risk with renal dysfunction, anemia on steroids, how to keep your kidney function stable while doing a PCI, managing comorbid conditions, and maybe a bit of discussion around stent choice and dual antiplatelet duration given his comorbidities. Next slide. So I don't know what you think so far, guys, about that. We'll just show you our pictures here. We have, so because the right radial was used before, actually the right radial pulse was very weak, so you have a choice to either go left radial, distal left radial, which is certainly a growing fashion, or as we tried here, ultrasound-guided puncture of the right radial, which worked fine. So even though the right radial pulse was very poorly felt, ultrasound guidance with a dedicated vascular probe allowed us to get in and around. And here's the spider view. Next. A PA caudal. Next. And an LED. Mark, I don't know if you want to take any particular comment, but...
No, I think you've summarized it very well, Colin. I suppose we'd be interested to hear what the panel views are, and perhaps Colin's framed the conversation for you.
Can we get a much more cranial view of the proximal mid-LED there? We got the circumflex overlapping it.
Right.
I feel like I don't see that well enough.
Yeah, it's a little hidden behind the circ coming across.
Very cranial.
How's that? Now we have a vascular panel because this is a vascular room, so our steepness of our angles is a little difficult, but I think that outlines the proximal LED a little. Down by faint praise.
So I suppose the first question is, I mean, yes, we're trying to define the lesions for you. We certainly are pretty convinced. We've run an IVUS down the LED if you wanted to see that to help you with.
IVUS?
Sure, the IVUS would be helpful. You know, so you're not doing FFR. Or,
so can we put IVUS on main screen and do a pullback?
And we'll play. And just hit play, please.
So I think you have lesions which are calcified, whose we need to assess either by coronary physiology or imaging, and we've decided to do IVUS. So this is distal in the LED, which looks angiographically normal, and by IVUS is between 3 and 3.5, I think. Is that projecting okay for you guys over there?
Yes, we can see it.
Yep.
So you see the calcium coming in here now, at 9 o'clock. Tight lesion coming in.
So this is the mid-LED, so you can see it's calcified with an arc of around 270, and its MLA is 3.5 millimeters squared.
And then in the more proximal portion, you can see a complete circumferential calcification coming in now.
It's a nice,
Eggshell
nice
calcification.
big lumen there, though, but full of
Oh,
calcium.
yeah, I think that's right.
Full rim of calcium.
Full ring, not out of keeping with kidney disease, vasculitis. These type of conditions, I think, alter the calcific nature of the coronaries.
I think the mid-LED there is quite convincing, that tight area, which has quite a bit of calcium, area of 3 millimeters squared, which of course correlates pretty well with a very significant lesion in that location.
And correlates well with angina, and we also have the right. You can see then we're coming back into the left main,
I think
which
the
is
right is
large.
worse.
So I suppose, have you any
So-
comments or guidance and strategy? We have a wire down here, and we're interested in your opinions. We've got our own thoughts here.
Well, I mean, I think there are people, the lower volume operators, I think, try to go in here and take a non-compliant balloon, and I think it's not an unreasonable approach in a case like this.
Yeah.
If you go with a 3 millimeter balloon at 18, 20 atmospheres, and you get full balloon expansion, you probably, since it's not 360 degrees down in that mid location, you probably can expand a stent fully without necessarily having to remove calcium. On the other hand, if you have a waist on the balloon at 18, 20 atmospheres, and you just cannot expand it, go to 22, maybe, I don't know if you want to go to a bigger balloon at high pressure. If you cannot dilate it, and there's this mantra that you cannot rotablate, for example, or use atherectomy after ballooning, I totally disagree with that. I mean, it's actually, you remove the edges of the calcium quite effectively, and I think you can interrogate the vessel with high pressure balloon and then use rotablator, for example, as backup. Or you could start with rotablator, which would be a fair option as well. Just make your life simpler. Just jump in right away.
So we have two options here available to us. So we felt we are 6 French right radial. We have a Voda left 3.5, and we tend to find for radial PCI 6 French really, apart from some of the more complex bifurcation and CTO work, gives us the full range of what we need to do. My thoughts were, although there is a healed plaque in the proximal LED, the proximal LED luminal area is good, and we would try to focally address that severe mid-LED lesion. On IVUS, I think if we can just go to the bookmark of the mid-LED lesion, there is a significant calcification, and we have the luxury of having shockwave intravascular lithotripsy here, which I think is a very reasonable upfront balloon to use to try to modify that calcium.
I think that's a great idea. We just don't have it in the US, but that's a great idea.
I think that's coming to you. And I think one of the points that we would like to mention is that, and I know that Margaret McIntyre, Professor Oldroyd, and Mitchell Lindsay were presenting at TCT, is the algorithm for calcium modification must include upfront imaging and understanding of the calcium so that we don't fall into the trap, which I think is increasingly common, of early stent failure due to stent under deployment and failure of modification of disease. So 1040 cranial, please. So for people in the audience, the shockwave balloon basically is a standard, is a lithotripsy balloon which goes up at 6 atmospheres, and you can deliver 80 shocks to the target lesion in order to modify.
So I think you're just catching on the right-hand side of your image the console that it attaches into. Many of you probably use it perhaps in your peripheral practices, but it's a console which is pretty easy to use. We've just covered a sheath in the distal aspect, and You can see the sort of handle here with the light glowing.
Now, I can tell you there is a significant amount of
Resistance.
to get this balloon around.
So it is a bit bulkier than a standard system.
So can I have a 2.5
so we will modify.
balloon, please? So one of the downsides, I think, of the shockwave balloon potentially is its deliverability compared to standard balloons. So we're just going to take a 2.5 compliant balloon just to maybe
Guide catheter extension just now as well.
Yeah, I
see
think
what we
this
can
is
do.
this
Can I have
is
a
one of the
guideliner,
problems
please?
with this balloon.
Guidezilla, please, as well.
My friend
Yes.
Richard Schlafmitz, who's done like 50 of these in the U.S. trial, and you're not allowed to pre-dilate in the U.S. trial, and he tells me that half of those, 25 of the 50 cases, he cannot deliver the device to the lesion. So if you can
So what we're
pre-dilate, then
doing-
which I think is fine,
Yeah.
by the way, but in the U.S. trial, you're not allowed to pre-dilate, so you have troubles with delivery.
They're tying their hands behind their back a little, yeah.
Yeah.
So,
So-
what Colin has taken here, he's just taking a guide cath extension, so we'll kind of do that just to help ease our way also. So once the balloon goes down, we'll sort of nudge it into the proximal vessel just to take out some of those friction
So there
areas.
is a Boston Scientific guide extension just to give us a little bit more push. And I think that's a very useful adjunct to have in complex practice.
So here, we'll pop the balloon up then, and that'll help us get this down. Wire pinned.
The one advantage I suspect of road ablation is that I think it removes vessel friction slightly more effectively than.
Yeah.
Now, what you can see here, this is 2.5 balloon, and this is something you never want to see. Can you appreciate there's relative wasting and not expansion of that mid-LED lesion? And back down.
Yes.
So I think, as you were alluding to, palpating the lesion.
I'll just go up there
Go up
gently.
there.
Yeah.
Do you use the balloon itself to pre-dilate your way down and sort of nose your way through?
Yep. Yes, and down, up, up.
Guide, you're happy?
That's what you're doing now.
16. We are doing that. So we're doing a kind of balloon-assisted tracking of the guide liner down, and we're going to now take that shockwave balloon. So we've advanced the guide liner down past that proximal calcification, which is certainly adding to the friction, I think, overall of the case. And
Okay. They pre-dilate.
So in your practice, how often are you forced to pre-dilate before using the shockwave balloon?
I mean, I wouldn't say we were forced to. I mean, to be honest, we were just trying to show it to speed along there. We thought we perhaps slightly underread the calcium and thought it would get down, but typically we would pre-dilate.
yeah, I think I would agree with what was said in the panel. Taking a balloon up front to palpate the lesion, it removes some of the edges of friction, and then placing the shockwave balloon down afterwards would be reasonably standard practice. In short focal calcifications, we don't tend to pre-dilate. Just watch that distal BMW wire just coming through. So we've got a better platform now for delivering this balloon. Wow.
Still
I
won't
think
go.
we'll just start there, Mark. Yeah, I think in terms of where we are, it's engaged some of the calcium, so we'll maybe try go up to 6 atmospheres.
So we're just going to go to 4, because sometimes the balloon's a little bit prone to rupture. It's quite a thin wall, so we'll go to 4 atmospheres.
And maybe we'll just...
we found it maybe it's a little prone to rupturing if we go to the full 6.
guys,
And we're going to
we've just no pressure on the...
tap open.
The guide extension.
I think you're right, though. We
cannot
haven't
deliver the
delivered
shockwave.
to the lesion just yet.
on the screen.
I'll just do 10.
Just I can press that for you. Guide it. Just hide your guide.
Down.
up. So we just delivered a train there of
It's not going.
guide. Okay.
Yep.
The guide's out.
Let's get your guide up stronger.
Won't go.
Okay. That was it.
It's pushing on the cusps.
Can you hear us okay? There's a little bit of static coming across in our...
And down, Mark.
there we we go. It's nudged forward a little.
I'll just
So
give you
as you crack, if you will, the calcium a little more proximally, does that often help you get the shock wave down a
Sometimes,
little
yeah.
further? You sort of get some distal shock, if you will.
I think that's right. We're not getting wonderful support here. We'll tighten up our guide here and try and get the Guidezilla closer. The guide is hanging down into the aorta, so it's nudged forward a little bit there. You can see there's a bit of curvature here, just has to round that area. But I think it's got more engaged into the calcium now. So that's one more train there of.
Yeah, I think you're pretty close to where you need to be.
I think we've nudged forward nicely there. So we'll get the Guidezilla back down. It's just a bit of push-pull here in the support.
3-0. Okay.
Looks a little big. No?
Guidezilla back in.
I will.
Olivier, you know what they need?
Okay. Is that balloon burst?
No, it wasn't. Unless it just did. But
You'd have a sheath across. For the shock wave.
yeah.
Balloon's burst.
So the balloon is just ruptured there, which is one of the things we do see. That was 4 atmospheres or so.
The shock wave balloon ruptured?
Yep,
Yeah,
we have
yeah.
rupture, which kind of shows you the aggression of the calcification. Well, we've delivered 40 shocks, so I think it's reasonable at this stage to try a 3.0 non-compliant balloon
So
and
3.0,
see
15
how we are. And if that does not modify it enough, we will go up front with rotablation. What's the
So NC.
So after the shock
doing a
wave,
non-compliant
is it typical for you to use an NC balloon after the shock wave, again, just to make certain that the shock wave disrupted
Yeah,
the calcium?
we would tend. I mean, that
Absolutely.
would tend to be our practice. Just so we don't underread the situation. We would go back with another shockwave balloon here if there's any worry that we haven't got stuff up.
And you would
Yeah,
not
it's
go
easy.
directly with a stent here until you're convinced that the shock wave
No,
had
absolutely
disrupted
not,
the calcium.
yeah.
And I think that's an important take-home message for any calcific disease, is to try to resist the
Impulse to.
stent to resolve problems. You have to demonstrate that you have modified the calcium, and then you can deliver a stent thereafter. Okay, so what turned out to be not a too bad looking lesion is behaving reasonably aggressively, and this is what we see with calcified disease. So we're just going to go around
So
the
the
corner.
NC has tracked reasonably there,
Yeah.
and that's us at
Better than the
12,
shock
14.
wave.
Yeah.
Yeah, that's definitely the reality. There's quite a bit of technology packed into
Okay,
the
and up.
Yeah.
device.
Could
So
you
I think
see?
that's just.
There's still a little
And that's
waste
burst,
on
so
the
that shows it-
proximal, isn't
No,
there?
it just burst there. It just burst.
It burst.
It ruptured, so we
So we
will.
do not have modification of this calcium.
So is that a sign that you did not disrupt the calcium well enough, or do you see the balloons bursting when you make these calcium fractures that have sharp
No,
edges?
we don't. We haven't had that signal that's the case. So I suspect there's 2 ways that we can deal with this now. We could upfront burr to try and remove those shards of calcium, or we
go
could
with
try another IVL. Guys, can we have a 3.5 shockwave, please? So I think it's reasonable to try another attempt at modifying this with shockwave.
So we'll take the time to have another go with a new shockwave balloon, and then we're back over to then the discussion. We then modify with a burr if that doesn't satisfy ourselves.
Yeah, the only issues we get into here is now you have a 6 French guide, which limits you to a 1.5 burr, and that's probably just going to slide right through this thing. I mean, you've modified it well enough that a 1.5 burr probably will not debulk it very much. I mean, it still works a little bit. It can take the rough edges off.
It'll shave the spiky bit
Well,
probably.
you can get a 1.75 down a 6 French without much
Can you?
problems.
Yeah,
I
that's
find.
it. Okay, still a bit of a tight fit.
We've got the Mac version of the VL here, so the Mac has a little more space in it.
A little bigger ID.
Yeah.
Yeah.
Okay.
Now if you go take out the guideliner, the Guidezilla.
That's true. Yeah.
Okay, come with me. It's still.
Got it.
Yeah.
So
I think that's round the corner,
It's
guys.
only-
Now,
it's-
so we're going to just.
it certainly travelled much easier there, Colin, and you hadn't. I'm just going to go to 4 here, and I'm mindful of the rupture.
There's another
I think that-
shockwave balloon, correct?
Yeah,
That's
this is
another, a
this is
fresh one.
This is a 3.5, and I think
3.5.
you can see now that it's modified that calcium a bit better.
No,
Well,
I
we'll
think
give it a
that's the
good-
right size there.
A good series of treatments here.
Can I have a
Distally, the
3.5?
vessel was 3.25 by IVUS. I think 3.5 here at low pressure. is
Yes.
good.
We're
Yeah.
at 4 atmospheres with 3.5.
Go again.
So what we want to ensure is maximal contact with the vessel wall to deliver the shock wave.
That looks nicely
I think we're
expanded.
getting
Right where the other
think
balloon
so.
at high pressure was not expanded. I think that looks very
Yeah.
good. Very promising.
And that is the point where the NC ruptured. So I think that is a sign that, you know, we hadn't modified the calcium
That's a
enough.
very good
So
sign right there.
Just to understand, I don't have experience with the shockwave, so how do you calculate the number of shocks you're going to be delivering? I mean, you deliver shocks until the balloon is fully expanded, or how you, what's the kind of
least,
protocol
yeah.
you do?
Well, our protocol is that you have 80. We don't necessarily have to deliver all of those 80s. And certainly for a longer lesion, you might need those shocks to deal with the entirety of the vessel. Down, please. But typically for an aggressive calcium, are you okay, sir? Up there now. Just hand down. Somebody just check on him,
Just
please.
check he's comfortable there.
Okay.
So yeah, we definitely want to be confident that the balloon seems expanded. So I think we're seeing good sign of that. You may be getting a little bit.
That looks
let's
very
take a
promising.
3.5 balloon now.
Take a picture
Okay.
and see what happens.
Right,
Wee
so,
bit. He's getting a little bit of
please.
discomfort. So clearly we're in a important vessel.
so Dan, morphine, please.
STs look funny.
He's getting a little bit of ischemia.
So at this stage, we're going to try and deliver a 3.5. I'm going to back my guideliner out to give the vessel a little bit of breathing.
You can keep that.
And we'll take the
burst.
3.5.
So you're going to go
NC.
back with another NC and just confirm this? Is that the idea?
Yeah, absolutely.
Absolutely. I mean, I think that is a very reasonable thing to do to ensure that you have modified this calcium.
Excellent.
But at this stage, with the 3.5 shockwave, I think looking better expanded, I'm more comfortable that we have modified this mid-LED. And although this isn't a highly complex case in terms of road ablation, complex bifurcation, I think it highlights, and there, look, a 3.5 goes around the corner, no problems.
So here we go.
Yeah, and I'm happy with that.
Totally
Press any
different.
on and off.
Totally different.
Okay.
And another V6 back slightly. Or we think we're
Right, can we
okay
have
there.
IVUS, please?
Just go there. So that gives us a lot of comfort.
Excellent.
So what we might, I think, you know, at this stage I might consider just going ahead and implanting a stent, but since we're in educational mode and not in
You're gonna
sometimes
IVUS it
real
first?
life, we're going to IVUS and let's see the effect multiple runs down this artery has had.
So ready for a new run on IVUS, folks?
Some might go as my direction,
I
thanks.
think it'd be very interesting for us to
ACT
see what that
walls.
looks like.
268? Okay, can I have some extra heparin? Just a point about ACT. I know following some Twitter chat, we have also found some under-therapeutic ACTs with more than 100 units of heparin. So we've given 10,000 here, and our ACT is 268. So we're just keeping a close eye on that, particularly when we have a lot of equipment down the vessel.
Okay.
Come with me. Okay, guys, stand back, please. Just screening.
Traveling okay?
Traveling fine.
Not kinked on you, no. So
There we go.
another good sign the IVUS has traveled.
So
And here's a pullback.
I hope you can see this. So we've just gone past the mid-LED and we're pulling back. I think the distal vessel is relatively normal. You've some disease down there between 3 and 9 o'clock. And we are coming up to the area where we have modified in the mid-LED. You can see some lines of fracture there and definite adaptation of the mid-LED. There's a fracture line there running from 12 to 9 o'clock. and more fracture lines at 4, 7, and 8 o'clock.
Yeah.
Can you appreciate that? Or do you want us to scroll the IVUS back?
No, we see them pretty well.
Beautiful pictures.
Very nice.
So maybe we'll just, Mark, maybe do you want to scroll back on that and show the lines of fracture while I rethink a 3028 or something?
20 or 20, 24, 28, something like that.
Give us a 3028 length
stick a
Onyx and then a
measurement.
35 NC,
I can
please.
hop around and stick a length
And then
on
I'll
it.
take a 35 and 40 NC, please.
I'll go around and just measure that.
So
on
maybe
IVUS
while
here.
we're getting the stent ready, so we are choosing the Resolute Onyx stent today based on the publication of Onyx 1, which showed safety of discontinuing dual antiplatelet therapy after 1 month in a gentleman we feel is at increased risk of bleeding due to his comorbid conditions. I don't know if anybody on the panel would have any particular disagreement. We tend to use Synergy for its biodegradable polymer platform, or Onyx since the Onyx 1 release at TCT.
Yeah, I think almost all the main DSs, Synergy, Onyx, and now even Zions has some data that will be coming out on very short depth. I think what we've learned is that these newer polymers and the Synergy, of course, which only has the abluminal polymer that dissolves, are pretty safe for 1 month
So,
Um,
in high-risk patients.
I think, just sorry to interrupt, I think what we have,
So 22 even, Colin? 23 for
26.
an Onyx? Or 26 would be fine.
so I think what you can see is a line of fracture at the tightest part of the LED up there at around 9 to 10 o'clock, yes?
Yeah.
And then if we just, maybe Mark will let it play from, if you let it play from
In
back a
here?
little bit, there's clearly lines of fractures there, disruption of
here.
the calcium.
Right here.
It's interesting that they're relatively focal, and I think it's an important observation just in general for the mechanisms of angioplasty, where balloon angioplasty works by focal plaque release. That is this sort of a piece of porcelain inside a compliant tube, and you just have to crack it at one place to open the tube. And I think this is creating that focal crack
Look, go back one, Mark. Just
that restores the compliance of the segment.
so keep going, keep going, keep going. Do you see there? There's really very significant disruption of this calcium with the shock wave. Do you see a big fissure line there at 10 o'clock? So we would be reasonably confident that we can then place this Onyx stent in, optimize it, and get a good result. And I think one of the dangers with calcium, particularly of this nature, which is almost circumferential, is undertreating, underpreparing the vessel, and then having a stent, which is very difficult to treat. So at this stage, probably around the corner is fine. I'm just going to bleed back. So we've chosen a 3026 Onyx based on the longitudinal length. We're just going to go around that corner, and then obviously IVUS optimize.
And a little bit, yeah.
There.
Okay, fluoro.
Yeah, go for it. I think that looks good, Mark. And there's the proof of the pudding, a well-expanded stent. Okay, and
Can
down.
you put the angio on your main screen?
Could we put angio on main screen, please?
Is it possible to use the shockwave as a therapy if you basically realize that the stent remain underexpanded, basically to crack
and
some plaque behind the stent struts?
Yeah.
That's
And
a
so
great question.
I mean,
Olivia.
sometimes we have some cases that get sent to us, as to be
Okay, we'll
done
take
to
the
be done a few
3.5
days
NC,
later.
please.
If maybe
And
in the
then
middle of the
4.
night someone has had trouble or whatever.
So what you're saying, use the 3.5 NC, 15.
Have you
You're
ever
saying
put it
use the
through a
shockwave.
fresh stent that's underdeployed? You go in thinking you can
We have.
deploy it, you put it in,
We
you
have.
cannot expand it, you post-dilate it, cannot expand it. Have you ever taken an
Yeah.
acute fresh stent and tried to
Yes,
get it
we
expanded?
have. We actually, one of our fellows who's now training presented at EuroPCR a case of exactly that, of a prepared lesion where there was significant wasting, couldn't be rescued with a high pressure OPN balloon, which was rescued 2 days later with a shockwave. So although in theory it's a contraindication. We certainly have used it
Okay.
to rescue cases.
Better to use
Visitors
it up
Hotel,
front,
NC.
like most stent deployment. Better to get it right the first time.
Yeah, I mean, isn't that the caveat and down? 16 atmospheres will take the 4.0. 12, please.
Yes, Don.
So the 3.5 NC balloon went up perfectly well there, and now we're just taking the 4.0 proximally to optimize it, and then we'll do another IVUS run. Set up for another IVUS run, please. And I think the penalty, even for relatively straightforward calcified lesions like this, of an underdeployed stent in a patient who has aortic stenosis and is relatively elderly, it can be quite significant. And in-stent restenosis, when it occurs as a stent failure model, you know, the panel knows, is very difficult to correct. Once it starts, you're in trouble.
You know, we
So
started
perhaps
with...
we'll do stent boost for the top end, please.
We
Just box
started
in
with
onto the
bigger
stent,
is
please.
better back in the 1990 with stenting and ballooning with
Yeah.
Don Boehm and Rich Kuntz. And, you know, even with DES, bigger is still better. Bigger is still better. And I think we get lazy with DES and not expanding them. And we end up with the results that are much more challenging to fix after they restenose. I always tell the fellows,
That's not
your
stent
best
boost.
chance is your first chance.
Yeah.
Just go and nudge in, I think, Colin.
Imagine.
Just pushing the marker in slightly. Often with the calcium, it is hard just to see these modern stents, even with the platinum in the
Okay,
mix.
and down.
15 and down.
So we're going to do a poor man's IVUS here. We're going to do a stent boost just to kind of look at the length of the stent. Yeah, Miles?
In terms of safety compared to rotablation, have you ever seen vessel perforation as a result of delivering shockwave, or the mechanism is different
We
and the
haven't.
safety is better?
Thankfully, no.
We haven't yet. And I think for focal lesions where you can deliver the balloon safely, it's a very safe treatment. You're talking about 4 to 6 atmospheres and delivery of shock for, you know, calcium modification. And we haven't had a perforation. And I actually think it's more likely you will perforate and do damage, nitro please, to a vessel when you're going ultra high pressures to try and modify calcium, which will shatter, rather than low pressure shockwave, which is going to behave
I
much
think it's be
nicer.
very
So I
low
think
perforation risk. How about no reflow? You ever see a slow reflow event after shockwave?
we haven't as of yet.
I think
let's find out now.
Anecdotally, it's a little certainly less likely than with Rhoda, you know.
PA Coddle, so what do you think, guys?
The only problem is the stent looks so beautiful, the proximal part of the LED looks less good. But,
We were
you know,
just commenting on that, yeah. So
but the other
we'll look
thing,
at it
this
on
is
IVUS,
not
I think,
plastic
as well.
surgery.
No, I think we might have to do another.
I think you did a great job in it.
Well expanded.
We'll
The
do
stent is
IVUS, keep us
fantastic.
here.
Yeah.
Stent is well opposed. The calcium has been modified. I suppose the only itch to scratch is whether we
Overlap.
cover that proximal lesion. Now on IVUS, the MLA looks fine, so I'm inclined not to.
Yeah, you know, whenever we get great stent results, the disease around it always looks much worse than you thought. And then you go back and look at the,
Yeah.
I tell the fellows, go back and let's look at the first picture. Would you have stented that lesion? Look at the first IVUS. Would you stent this lesion? And if the answer is no, you know, the other answer is this is not cosmetic surgery. It's not plastic surgery. We can make the
So
vessel
just
look
can we
better.
run the IVUS, please, for the rim, please? Put it
So
on.
we'll put IVUS on main
put it on-
screen,
on-
and
yeah.
then we'll see what you guys think.
Put it on there, yeah.
I think the IVUS is important here. So if the MLA is, you know, 10 millimeters squared or 9 millimeters squared, I mean, you definitely do not want to touch this
It's
thing.
ready for bookmark, please.
So there's the distal vessel. Want to make sure that there is no edge dissection, that we've landed relatively in an area free of disease. But the MLA is good.
And bookmark there.
Yeah, I mean, that stent distally is
Beautiful.
fine.
So nice and circular,
That's
well
perfect.
opposed.
Look at that.
Very nice.
For a vessel with that much calcium to get that much symmetry, a litlittle less symmetric there. That's the
There's a
tough
little bit
calcium right there.
D-shaped there, but not bad.
Not bad.
Just bookmark there.
I think that's the area where the most constraint was, and we have, I think, a well-expanded
It's well
stent.
opposed in this section. So we're coming close to the, probably a little bit mal over there.
Now, you're
We
about
could
to
probably
come to
keep
that
it
area we're
larger.
worried about, or not worried about.
Yeah.
We have perhaps have
Two struts
three
off,
struts
maybe.
there
no.
that we could probably tidy up on.
4-0.
We did take a 4.
Right there.
You're about at the area
guess
that
just
we're worried about.
There it is, that eccentric shape, isn't it? It's the calcium
There,
shielding.
right there.
there.
That's the spot. But it's
Just
3 by
bookmark
3.
there and we'll come back.
It's 3 by
So
3
I
millimeters.
would. I
Yeah,
think
we-
by
I'll do an
IVUS,
area for you.
we are fine here, so I think we will leave that well alone.
We'll
Great.
come back and just stick an area on that for you.
It's very high definition. It's very nice.
I think
So
you
yeah,
guys
this is
did
the Boston
very
high def
thoughtfully
IVUS
approached.
we're using.
Very well done.
So we're going
So
to
Colin, I think there's the tightest area there. We'll just stick a
can I have that
trace assist
4
on it.
ONC,
Get a
please, again?
CSA.
so our MLAs.
10
we can make
millimeters
that
squared.
bigger.
Or 7? 7. 7
We're out to
millimeters squared.
7.
7, okay.
Beautiful demonstration of the use of IVUS. I mean, the pictures
7.3.
are amazing. I mean,
You know what? That's great.
yeah.
So Colin, just to look at that little area in the middle, where the most
What's the cross-sectional area right in that constrained part where, you know, the most
We
calcified
are
area?
just there is the constrained part there, and we have a CSA of
6, yeah.
easily over 6, approaching 7.
You know, that's good.
Well expanded.
So we have a well-expanded stent in that area.
So
with
7.1
cross-sectional
I've
area.
managed to get, and I think that's not overdoing it. So
And again, you don't want to finish a case with a sunroof, as my friend Colin Hanratty would call it. You know, so we are being reasonably respectful in the post-dilation here, because there still is calcium in the vessel wall, which we could, in theory, cause issues with. I'm just
know-
going to, based on IVUS, there was a few struts which I think we can push out a little
Antonio
bit more.
Colombo loves to put big
20
balloons at very
atmospheres.
high pressures, but he also creates a lot of mushroom clouds. We hate mushroom clouds.
exactly. Well, we were calling it a sunroof there, but I think mushroom cloud is probably a nuclear cloud, maybe, or mushroom
Yeah,
cloud.
it's like
yeah.
a nuclear
and-
explosion and similar scariness.
Yeah, exactly.
And as the panel be well aware, dealing with calcified perforations is a different beast than non-calcified vessels, because your ability to deliver covered
Can we go
stents,
steeper even in that picture? Yeah. That's
I
good.
think that looks good.
That's
Okay.
That's,
angiographically
size.
at the lesion site, very, very nice, amazing.
Yeah.
Okay, that's us done here. Okay, exchange wire and JR4 guide.
So much more time have you with us? Have we?
How much more time do we have?
I think we only have 5 minutes.
We have 5 minutes.
I don't think
Well,
we have
let's
time
see.
to do the right
we'll
corner,
quickly
though
pop
we'd
the
love to see
guiding
it.
catheter
We're
into
turning
the
our
right and see.
attention. We have the right. We can turn our attention to that. You can stay with us, and
We're going
we
to just
appreciate you for a busy program. So
to summarize the teaching points, we think of the left, we used ultrasonic guidance, right radial access due to a diminished pulse. We, due to comorbidities, chose the Onyx stent for the ability to prescribe 1 month of dual antiplatelet followed by single. And we used IVUS to outline calcification and delineate our calcium modification strategy. And I think all your comments about the shock wave deliverability, potential rupture with this aggressive calcium are well taken.
That was a
we're now
terrific
turning our
case.
attention to. Sorry, go ahead.
Terrific case, a beautiful demonstration, nice combination of angio and IVUS. I mean, congratulations to all of you.
Very nice case. Well
Thank you
done.
very
Thank you very much.
Thank you.
See you next year.
That's awesome. That's great.
Okay, so I think we are right on time, so that's good for a morning session. So I'm going to call Dr. Amignan, Dr. Bernard, Dr. Kedev, Dr. Lemay, and Dr. Segal for the next sessions, which probably one is also going to be quite interesting. I just want to remind everybody that if you want to participate at the cruise, the traditional cruise tonight, please go to the registration desk and mention it, because we're going to, the staff will grab the tickets during lunchtime. So after lunchtime, it won't be possible to register. So please, if you are interested, let us know.